Mechanism of action of insulin. Insulin is a peptide hormone that binds to transmembrane tyrosine kinase receptors on muscle, adipose tissue, and liver cells, triggering cascading metabolic effects throughout the body. Let's see how insulin works at the cellular level. Insulin first binds to its receptor, which is a transmembrane tyrosine kinase receptor. This activates the IRS PI3K AKT signaling pathway, the key intracellular cascade responsible for insulin's metabolic effects. As a result, GLUT4 transporters move to the cell membrane, allowing glucose to enter muscle and adipose cells. This is the primary mechanism by which insulin lowers blood glucose levels. Insulin has three major effects on carbohydrate metabolism. First, it increases glucose uptake into skeletal muscle and adipose tissue by promoting GLUT4 translocation to the cell membrane. Second, it stimulates glycogen synthesis, promoting storage of glucose as glycogen in the liver and muscle. Third, it reduces hepatic glucose production by inhibiting gluconeogenesis and glycogenolysis. Together, these actions lower blood glucose levels and promote energy storage. Insulin is a strongly anabolic hormone that promotes both fat storage and protein synthesis. In fat metabolism, it increases lipogenesis, encouraging storage of excess energy as fat. At the same time, it inhibits lipolysis, reducing the breakdown of stored fat and suppresses ketone body formation. In protein metabolism, insulin increases amino acid uptake and stimulates protein synthesis while reducing protein breakdown. Together, these effects promote growth, preserve muscle mass, and support energy storage. Insulin also has an important electrolyte effect. It stimulates the sodium-potassium ATPase pump, causing potassium to shift from plasma into cells and thereby lowering plasma potassium levels. This is clinically significant. Insulin is used therapeutically to manage hyperkalemia in acute settings. To summarize, insulin is the body's principal anabolic hormone. It promotes storage of glucose, fat, and protein while inhibiting their breakdown. In carbohydrate metabolism, it increases glucose uptake and glycogen synthesis while reducing hepatic glucose production. In fat metabolism, it promotes lipogenesis and suppresses lipolysis and ketone formation. In protein metabolism, it stimulates protein synthesis and reduces protein breakdown. Finally, insulin drives potassium into cells, lowering plasma potassium levels. Together, these actions make insulin the key hormone for energy storage and nutrient utilization. Basis of different insulin durations. Different insulin formulations achieve their distinct onset and duration profiles through specific molecular and physicochemical mechanisms, from amino acid modifications to depot formation and albumin binding. Rapid-acting insulins, Lispro, Aspart, Glulisine. Small changes in the amino acid sequence reduce the tendency of insulin molecules to form hexamers. Therefore, insulin remains mainly in the monomer form, which is rapidly absorbed from the injection site, resulting in a rapid onset and short duration of action. NPH or isophane insulin contains protamine, which forms a protamine-insulin complex that dissolves slowly after subcutaneous injection, producing an intermediate duration of action. Zinc present in the preparation helps stabilize insulin hexamers, further slowing absorption from the injection site and extending the duration of effect. Insulin glargine precipitates at physiological pH, leading to the formation of a subcutaneous depot, from which insulin is released slowly and steadily, providing a long, relatively peakless duration of action. Insulin detamere binds to serum albumin after subcutaneous injection, delaying distribution and prolonging its duration of action. Insulin degludec forms multi-hexamer chains in subcutaneous tissue, allowing very slow and sustained release into the circulation. Insulin icodec also forms multi-hexamer chains in subcutaneous tissue, enabling an ultra-long duration suitable for once-weekly dosing. To summarize, the duration of action of insulin preparations depends on how quickly they are absorbed from the injection site. Rapid-acting insulins remain in the monomer form and are absorbed quickly. NPH insulin forms a protamine-insulin complex that dissolves slowly. Glargine forms a subcutaneous depot after precipitation at physiological pH. Ditamir binds to albumin, delaying distribution, while degludec and icodec form multi-hexamer chains that release insulin very slowly, producing ultra-long durations of action. Adverse effects of insulin. A clinical overview of the key side effects associated with insulin therapy, from common metabolic changes to rare complications. Hypoglycemia is the most common and serious adverse effect. Causes: excess insulin dose, missed meals, increased exercise. Symptoms: sweating, tremor, palpitations, confusion. Severe cases may cause seizures or coma. Weight gain occurs due to increased fat storage and reduced glycosuria, as glucose is retained rather than excreted. Insulin resistance may develop due to antibodies against insulin, obesity, or prolonged high insulin exposure. Lipohypertrophy refers to the abnormal fat accumulation at repeated injection sites, the more common form of lipodystrophy. Lipoatrophy is the loss of subcutaneous fat at injection sites, relatively rare with modern insulins. These complications can be best prevented by rotating the injection sites regularly. Hypokalemia. Insulin drives potassium into cells, lowering serum potassium, a clinically significant electrolyte shift. Insulin edema, a rare complication causing fluid retention and peripheral edema, typically seen shortly after initiating insulin therapy. To summarize the adverse effects of insulin, the most important is hypoglycemia, which can occur with excess dosing, missed meals, or increased physical activity. Insulin may also cause weight gain due to increased fat storage and reduced glycosuria. Because insulin drives potassium into cells, hypokalemia can occur. Less common adverse effects include insulin edema, particularly when therapy is initiated, and lipodystrophy at injection sites, which can be minimized by regular rotation of injection sites. Before we conclude, remember that safe insulin therapy requires both regular monitoring and patient education. Patients should monitor their blood glucose regularly to detect hypoglycemia early. Injection sites should be rotated consistently to prevent lipodystrophy. In addition, serum potassium should be monitored in high-risk patients, as insulin can shift potassium into cells and lower plasma potassium levels. These simple measures help maximize benefits while minimizing adverse effects. Hypoglycemia due to insulin. It is the most common and most serious adverse effect of insulin therapy, occurring when blood glucose falls to abnormally low levels. What causes hypoglycemia? Hypoglycemia usually occurs when insulin action exceeds glucose availability. Common causes include excess insulin with overdose or incorrect dosing, missed meals with delayed or skipped food intake, increased physical activity without dose adjustment, alcohol intake which impairs counter-regulation, renal impairment with reduced insulin clearance. Recognizing symptoms. Autonomic or adrenergic symptoms include sweating, tremor, palpitations, anxiety, and hunger. Neuroglycopenic symptoms include headache, confusion, blurred vision, drowsiness, seizures, and coma in severe cases. Management. In mild to moderate hypoglycemia with a conscious patient, give oral glucose 15 to 20 grams. Examples: glucose tablets, sugar 3 to 4 teaspoons dissolved in water, fruit juice about 150 to 200 milliliters. Severe hypoglycemia where patient is unconscious or unable to swallow. Intravenous glucose 25 grams intravenous glucose, usually as 50 milliliters of 50% dextrose solution. Glucagon injection when IV access is not available. 1 milligram intramuscular or subcutaneous in adults. 0.5 milligram intramuscular or subcutaneous in children weighing less than 25 kilograms. After recovery, the patient should be given oral carbohydrates to prevent recurrence. Prevention. Appropriate insulin dose adjustment. regular meals and snacks when indicated, frequent blood glucose monitoring, patient education regarding hypoglycemia recognition and management. Pharmacotherapy of gestational diabetes. The goal of drug therapy in gestational diabetes is to maintain normal maternal blood glucose and prevent complications for both mother and fetus. Insulin, drug of choice. Insulin is preferred because it does not cross the placenta and is safe for the fetus. Used when diet and exercise fail. Commonly used insulins include rapid-acting, insulin Lispro and insulin Aspart. Intermediate-acting, NPH insulin. Long-acting, insulin Detamir, considered safe in pregnancy. Metformin, oral option. Improves insulin sensitivity. Crosses the placenta. Available evidence suggests good maternal and fetal safety. Some women may still need supplemental insulin. Glyburide, less preferred. It is a sulfonyl urea that stimulates insulin secretion. May be used when insulin is not feasible. Crosses the placenta to a limited extent. Associated with a higher risk of neonatal hypoglycemia and macrosomia compared with insulin or metformin. Therefore, it is less preferred than metformin in many current guidelines. To summarize the treatment of gestational diabetes, the first step is always diet modification and regular exercise. If lifestyle measures fail to achieve target glucose levels, insulin remains the drug of choice because it does not cross the placenta and is considered safe for the fetus. Among oral agents, metformin is the preferred option and is increasingly accepted in clinical practice. Glyburide may be used when other options are not feasible, but it is generally less preferred due to its higher risk profile. Insulin resistance. It is a condition where body tissues like muscle, liver, and adipose show a reduced biological response to insulin, leading to impaired glucose uptake and elevated blood glucose levels. Pathophysiology. Normally, insulin facilitates glucose uptake into muscle and adipose tissue, while reducing glucose production by the liver. In insulin resistance, these actions become impaired, leading to decreased glucose uptake by peripheral tissues including muscles, increased hepatic glucose production through gluconeogenesis and glycogenolysis, and enhanced breakdown of fat stores. This results in hyperglycemia, and the pancreas compensates by producing more insulin. Causes of insulin resistance. The most common cause of insulin resistance is obesity, particularly visceral or central obesity, which is associated with increased levels of free fatty acids and inflammatory cytokines that interfere with insulin action. Genetic predisposition also plays an important role, with individuals having a family history of type 2 diabetes being at higher risk. Physical inactivity contributes by reducing glucose uptake by skeletal muscles. In addition, certain hormonal disorders such as Cushing syndrome, acromegaly, and polycystic ovarian syndrome can promote insulin resistance and impair glucose metabolism. Additional causes. Additional causes of insulin resistance include certain medications such as glucocorticoids, atypical antipsychotics, and protease inhibitors, all of which can interfere with normal insulin action and glucose metabolism. Pregnancy is another important cause, as placental hormones naturally induce a state of physiological insulin resistance to ensure an adequate glucose supply to the developing fetus. Important clinical conditions associated with insulin resistance include type 2 diabetes mellitus, metabolic syndrome, polycystic ovarian syndrome, and non-alcoholic fatty liver disease. Significant consequences of insulin resistance include hyperglycemia, hyperinsulinemia, increased risk of type 2 diabetes, cardiovascular disease, and dyslipidemia. Management of insulin resistance primarily focuses on lifestyle modification, including weight reduction, regular physical activity, and dietary control, all of which help improve the body's response to insulin. Pharmacological treatment may also be used when appropriate, with insulin sensitizing agents such as metformin and pioglitazone helping to enhance insulin action and improve glucose metabolism.